Thank you, Pam. I want to thank all of you for coming. I think what I want to say to long-term care when we're looking at healthcare reform is don't be left out. Get your invitation to the party, get your seat at the table, because there's a lot of activity already occurring out there. The idea that providers of different levels collaborate is not a new thing. We have always collaborated with hospitals, otherwise we wouldn't have census and admissions. But healthcare reform is bringing it to a new, real level. Formal relationships with strategic partners are going to become really important for all of us, all of the providers, not just hospitals, not just long-term care, but it's going to be important for everyone because we all are going to share responsibility. We're going to share responsibility for clinical outcomes. We're going to share responsibility for patient experience, care coordination, cost containment, and care transitions. These are all things that we take seriously already, but they're going to be looked at much more closely. The object is always going to be, as it should have always been, the best care for the best price with the best outcome for the patient. As we move into healthcare reform, one of the things that we need to start looking at is how do we identify our strategic partners. You're going to look at key acute care providers, physicians, and post-acute providers. It's going to be critical that we look at the post-acute providers in our area and look at what hospitals that we choose to partner with. Developing strong, positive relationships with those providers will only benefit all of us as we move through the healthcare reform and the healthcare delivery system. You want to identify physicians to work with. With everything that I read about healthcare reform, the primary care physician is becoming more and more important. You heard Gary talk about how they have increased the physicians that they have by 10 times. So we need to look at those physicians that we want to partner with that are interested in collaborating with us to bring those good outcomes for our patients. Look at the care that you already are able to provide. Look at what you already have in your continuum, and then identify the gaps in your continuum and identify those post-acute providers that you want to work with. You already have relationships with some of those people, so you're really not starting at square one. Greystone communities have always been very focused on quality and good outcomes. But with the transparency that's going to be required in healthcare reform, monitoring that quality is going to become more and more important. We can't just say we provide quality care. We have to be able to prove it. We're going to need to do things like track your readmission rate. That's going to become very important. It's very important to acute care. It affects their reimbursement. It's important to us because it's the right thing for the resident. Collaborate on clinical pathways. For years, I have argued that nurses in long-term care are a specialty. We are a specialty just like emergency room, intensive care, burn unit, pediatrics. Long-term care is a specialty. We can learn from the clinical acute care providers, and they can learn from us. Systems for smooth transitions are going to be crucial, and electronic health records are going to become more and more important. If you're not already tracking your readmission rate, start looking at doing that. Several of our communities have already started doing that. You want to focus on which diagnoses are causing your readmissions. The big three right now are myocardial infarction, pneumonia, and congestive heart failure. Share your expertise between your providers. consider having clinical educators from the acute care side come and help you develop clinical pathways to reduce that readmission rate and retain your residents in your community. Any nurse who has ever worked in long-term care can tell you that it is a difficult experience for an elderly person to go to the hospital. If we can keep them in our communities and take care of them in our communities, it's only a benefit to our residents. Look at some decision support software. I've talked about this with a couple of people during the event, and there are some unique providers out there and some entrepreneurs that are looking at some very interesting software to help nurses make those clinical decisions. It will help the nurses determine what steps to take to anticipate that acute exacerbation of a chronic condition and put the interventions in place to keep that resident in your community rather than sending them back to the hospital. Communication is critical. You heard Gary talk about how they have developed software or put software in place that allows their post-acute providers to look at the documentation that is happening in acute care. We need to look at that. A lot of our communities are already doing electronic records, but if those records don't talk to each other among providers, it's very difficult to share information. Think about things like having a liaison from your community visiting residents in the hospital prior to discharge, educating them about the transition and about the care that they're going to receive once they reach your community. And again, electronic medical records. Telemedicine. We're going to be diagnosing people through Skype. But think about it. If your resident can stay in your community with your clinicians doing the assessment and then sitting with the resident while the physician speaks to them through something like Skype and diagnoses and provides intervention, and then the resident just goes back to their apartment to live and have those interventions put in place, what a lovely thing for them to have as far as care delivery. Any of you who deal with an elderly parent know that even going to a doctor's appointment is a huge impact on their day. So now I want to talk about some of the reasons that I think a CCRC is well positioned for healthcare reform. If you look at the continuum of care of senior living and senior services, this chart goes from acute care all the way through post-acute. Over to the left is the acute care side. In the middle are post-acute providers. If you look at the blue, those are all things that either are currently or have the potential to be provided in a CCRC environment. We can do a lot of things in our communities. We can help keep our residents healthy and living and independent living where they want to live. Now, if you look at all of that in green, a CCRC is a perfect partner for an ACO. Why are the reasons that we would be a preferred provider? Well, wellness promotion, hospitality, customer service, care coordination through the continuum, and smooth care transitions. Wellness promotion. A lot of our communities are focused on wellness, as our residents are focused on wellness. You want to keep your wellness program vital and keep it where you are assessing that to see that you're meeting the needs of the residents. Nutrition education should be a part of your wellness program because nutrition and the lack of it is one of the primary reasons that the elderly decline. Social programs provide connection for our residents. It keeps them vital and engaged. Loneliness has serious health consequences for the elderly. Statistically, lonely seniors are 45% more likely to die than a senior that feels connected. So when you're planning those programs in your community and you're thinking, wow, I've got a lot on my plate, you may be helping to keep someone alive. Education for residents and caregivers. One of the big focus for healthcare reform is chronic conditions. When residents have chronic conditions, which most of ours do, exacerbations of those chronic conditions are what send them back to the hospital. Something as simple as CHF, when a resident has an acute exacerbation of CHF, they end up back in the hospital. But something as simple as instituting a program where you weigh your residents every morning that have CHF to pick up on that added weight that may mean that they are developing some issues, then you can intervene, keep them in their home. Hospitality and customer service. If you've been to the Greystone Event before, you've heard about hospitality and customer service. It is a hallmark of what we do. The patient experience is going to become more and more important in healthcare reform. I've read quotes from, I think one was from a physician, and I'm paraphrasing. I'm taking care of their illnesses, now I'm responsible for how well they enjoy it. But in long-term care, especially in CCRCs, we take how well our residents enjoy being there very seriously. So work on your hospitality program, work on your customer service, but more importantly, measure your success at it. Because if you don't measure your success, you don't know whether you're successful or not. Work within your community to facilitate that coordination among continuums. I was talking with one of the employees at Mirador, the executive director at Mirador, and they had a resident who came back to skilled nursing, had previously lived in memory support, and they couldn't get this resident to eat. But in that situation, in a CCRC, all they had to do was call up the people who worked in memory support and say, how did you get them to eat? So that's good coordination along a continuum, and we are unique in that we can do that. Some of the current initiatives that we have going on in our communities, and you'll probably recognize some of the things that you all are doing. We have communities that are already having affiliations with hospitals in their area. We have many communities that have robust wellness programs. They have trainers on staff. Pools are common, Tai Chi, Zumba Gold. We have communities developing additional business lines and services on campus. Increased presence of nurse practitioners. If you have a nurse practitioner in your building every day, you are going to eliminate a lot of those readmissions. Resident employee surveys so that we can see how we're doing with hospitality and customer service. Level of care committees and resident observation systems. Just because a resident lives in independent living doesn't mean that they don't have the potential to have an exacerbation of an acute condition. So when we have those level of care committees and those resident observation systems, we're able to anticipate and catch those things early. And then education for residents and caregivers on chronic conditions. We have a lot of communities doing a lot of education for their residents and particularly for their caregivers. Change is coming in the way care is organized, delivered, and reimbursed. And personally, I'm quite excited about it. CCRCs have an opportunity to become the post-acute provider of choice in their area. That's reason for all of us to be optimistic. We are truly a real player in this game. We're important, and we need to step up and meet that challenge.